Oxygen treatment is used to save lives. It can be used in an emergency, and it also can be used for long-term to short-term uses. Now, we're going to be considering one of the key things it's used for, which is respiratory failure. And there are two types of respiratory failure. So type 1 occurs when there are low oxygen saturation levels, and that can be defined as less than 8 kilopascals, or a saturation of oxygen approximately 90%. This can also occur with low or normal partial pressure of carbon dioxide levels. So the carbon dioxide levels could be affected, or they could be low. Could be normal or could be low, sorry. Type 2 respiratory failure, now that's most prevalent in patients with COPD because of an inability to remove carbon dioxide, which usually results in hypercapnia. Therefore, partial pressures of carbon dioxide are above the normal range and oxygen levels may be low or normal. Now, the excess carbon dioxide can combine with water to form carbonic acid in the blood, which in turn dissociates to bicarbonate and hydrogen ions, and that results in respiratory acidosis. Now, hypoxemia, where there's low oxygen partial pressures, can also occur in patients with oxygen carrying capacity of the blood is low, for example, in patients with anemia. So all patients presenting with hypoxemia should have hematinics tests performed to rule out these conditions, which is basically a series of blood tests. So now if we think about home oxygen therapy, this is used in patients with chronic hypoxemia, and that's defined as partial pressures of oxygen of less than 7.3 kilopascals. It could be related to symptoms of having peripheral edema, pulmonary hypertension. Now, typically, treatment involves using oxygen for a minimum of 15 hours per day, and this corrects abnormalities in blood oxygen for longer periods, particularly at night when hypoxemia is often greater with patients, for patients with COPD. Now, oxygen treatment should aim to achieve a target saturation of 94 to 98% for the most acutely ill, or 88 to 92% of those at risk of hypercapnic respiratory failure. Now, patients discharged with oxygen should undergo formal assessment for long-term oxygen therapy after a period of stability of at least 8 weeks to assess if oxygen is still required and that patients are compliant with treatment. All patients using oxygen at home should be referred to a home oxygen service, and that's to prevent indefinite continuation of oxygen therapy if it's not required. They should also be issued with an oxygen card and counselled on the use of oxygen. All patients should be instructed on the duration of use per day, so it should be 15 hours or up to 24 hours. Now, they should be also told about the symptoms of potential overdose, which include morning headache, increased drowsiness, and patients should be made aware to look for these symptoms. Emergency services should also be aware of target saturation and treat patients appropriately. Now, patients who exacerbate frequently and are unable to achieve an 8-week period of stability may require assessment for long-term oxygen therapy. Now, that shouldn't be prescribed during an acute exacerbation and should only be limited to patients with a saturation of oxygen of less than 92%. They also should be presenting as breathless and unable to manage without the use of oxygen. Now, patients assessed for long-term oxygen therapy are done so using pulse oximetry, and that's either with arterial blood gas or capillary blood gas tests. During a period of clinical stability, so the patients aren't actually presenting with acute symptoms, they should undergo 2 arterial blood gas measurements at least 3 weeks apart. And those eligible should be initiated on a flow rate of about 1 litre per minute and titrated up in 1 litre per minute increments after 20 minutes until the saturation is 90%. Arterial blood gases are then measured to confirm that the target oxygen partial pressure of 8 kilopascals or more has been achieved, and oxygen may be discontinued if clinical improvement is made and the patient is stable. So home oxygen should undergo formal assessment for long-term therapy after a period of stability of at least 8 weeks from their last exacerbation or discharge from hospital. So patients with COPD often require long-term oxygen therapy and the nocturnal oxygen therapy trial. And the UK Medicines Research Council trials, which took place in 1980, showed that long-term oxygen therapy treatment is appropriate in patients and can improve survival rates by around 40%, irrespective of chronic hypercapnia and previous episodes of edema or pulmonary hypertension. Studies have confirmed that patients with clinically stable COPD with chronic hypoxemia have improved pulmonary hemodynamics and life expectancy when treated with long-term oxygen therapy for at least 15 hours per day. It's also been shown to correct nocturnal saturation of oxygen, decrease sleep latency, and improve sleep quality for patients with COPD who develop hypoxemia. Now, patients receiving oxygen for 24 hours a day are at increased risk of increased carbon dioxide levels, and therefore the target saturation of oxygen for patients with COPD should be 88 to 92%, and target oxygen saturations for all other conditions should be 94 to 98%. There are other types of oxygen therapy. So another one is ambulatory, and that's the provision of oxygen therapy during exercise and activities of daily living. And they can be prescribed in patients with long-term oxygen therapy who are mobile and need or want to leave home on a regular basis. The type of portable device will depend on patients' mobility, and it has been shown that relatively few patients with COPD actually use ambulatory oxygen therapy for more than 4 hours a day. It has been shown to be effective in increasing exercise capacity and reducing breathlessness in those with exercise arterial oxygen desaturation. They can enable patients to leave home for longer periods of time and to improve daily activities and quality of life. Now, candidates for this particular therapy are already on long-term oxygen therapy or will have a partial pressure of oxygen above the limit for long-term oxygen therapy, but also show evidence of exercise desaturation. But prior to prescribing this type of therapy, you really need to determine the level of activity that person intends to carry out outside before they actually do give this type of therapy. To assess for whether a patient may benefit from this, they would ideally perform an assessment after pulmonary rehabilitation. And the initial assessment should be followed by a review after 2 months, when the true value of the ambulatory oxygen therapy could be judged by interview, diary card, and oxygen usage. And if it is deemed to be unhelpful, then it should be withdrawn. The other type of oxygen therapy is short burst oxygen therapy, and that's the intermittent use of supplemental oxygen at home, usually for periods of about 20 minutes at a time to relieve dyspnea. So it can be used to pre-oxygenate before exercise or relieve breathlessness as someone's recovering from exercise. It can be used to control breathlessness at rest, used in palliative care, and used after an exacerbation of COPD to bridge the time until a long-term oxygen therapy has been assessed and potentially been put in place. Now, when we think about oxygen delivery, so the oxygen equipment must suit a patient's lifestyle and enable them to remain as independent as possible. It can be delivered from concentrators, cylinders, or as liquid oxygen. Now, the concentrator is the most common device for long-term oxygen therapy delivery. An oxygen concentrator is an electronic device which takes room air and passes it through a filtering system, removing nitrogen, to supplying concentrated oxygen through a mask or nasal cannula. These concentrators are installed and maintained by oxygen provider companies. And oxygen therapy is delivered by nasal cannula or mask, as I just mentioned. The nasal cannula are more common due to comfort and tolerance, but can have variable oxygen delivery. Venturi masks are designed to deliver accurate concentrations where it's clinically important to correct oxygen levels, often during acute episodes. Now, smoking is contraindicated in patients taking oxygen therapy, and it actually increases the risk of house fires. So smoking and oxygen use accounted for about 10 reported burns in London between December 2013 and May 2015, 4 of which actually resulted in death. All patients using home oxygen should be encouraged to stop smoking, and all patients willing to make a serious attempt to quit should be offered pharmacological support and referred to a local stop smoking clinic. If they continue to smoke, a fire risk assessment must be completed for patients by the fire service, oxygen contractor, and health team to consider the risk-benefit of the therapy. This may result in patients being refused oxygen therapy outright. Patients also should not use e-cigarettes and chargers in close proximity to the oxygen, as these may cause the oxygen to ignite. So what type of patient education should you provide? Well, you would need to provide education around the condition requiring long-term therapy and the reason for its prescription. You need to explain requirements for taking long-term oxygen therapy for at least 15 hours a day and the principles of low-flow oxygen therapy. If someone's on ambulatory oxygen therapy, you should explain as and when that patient should be using it. Describe the principles of oxygen concentrator and if a patient has any other kind of equipment. You would also explain around the home servicing arrangements and electricity reimbursement that the patient can receive. You could discuss advantages of nasal cannula for oxygen delivery. But some patients, as I've said, may require masks. You may want to assess for the requirement for a humidifier. You need to stress about cigarette smoking. You could also inquire about the domestic situation with respect to installation of oxygen equipment or storage, and provide contact telephone numbers for nurse specialists or physiotherapists or the technician, so the patient knows who to contact for emergency breakdowns and problems. You could also provide advice on travelling with oxygen therapy, if it's appropriate, and what to do. And also ensure that that patient is getting followed up. So long-term oxygen therapy will require following up. The clinician will be looking for a stable patient, not getting any exacerbation of hypoxemia. They will be looking for compliance. So, for example, in ambulatory oxygen therapy, they'll be looking to see how well it's being used, to see if it can be withdrawn. And lastly, it's just about safety measures in the home. So even though oxygen isn't flammable in itself, it can increase the risk and the rate of burning, particularly problematic at around more than 20%. Some materials that don't burn in air will burn in oxygen, so that needs to be taken into consideration. Also, accumulation of static electricity is more likely to cause combustion in oxygen-rich atmospheres. So just that level of risk needs to be taken into consideration. So no smoking. Oil, grease or petroleum products mustn't be used near or on oxygen cylinders or concentrators. Patients shouldn't be using vapor rub or petroleum jelly, excessive amounts of skin lotion or face cream, aerosol sprays whilst they're receiving oxygen. They shouldn't be using oxygen close to any source of ignition or heat. Once they have finished whatever therapy they are receiving, they should turn off the flow of oxygen. If they have long lengths of tubing, then ensure that they are draped appropriately around various, furniture to prevent any tripping. And just make sure the tubing doesn't become kinked or occluded, because that can cause issues with the delivery of the oxygen.